shows the force moment diagram moving from one direction to the other. And so we're tracing this power, this progression of the center of pressure, and the patient can also give us that feedback as well. So when we're looking at this, we first look at, in the gait cycle, we could look at plantar flexion and dorsiflexion. Actually, in Jacqueline Perry's book, these were flip-flopped. It should be dorsiflexion, plantar flexion. As we roll over, do we see a difference with the flex foot? Actually, we do not. Do we see a difference in terms of the force moment? No. But when we look at the center of pressure or power, that's when you begin to see the effect or impulse of the foot, the late stage stance flexion. And this is what the patient's feeling in late stage stance. So in engineering, what we try to do is base this on engineering math. You don't have to understand this necessarily. Some of you, I'm sure, do. But with the cantilever, it has to build up enough potential energy to develop that resistance. Now, your human foot doesn't need to do that because it has the use of variable power of the muscles. But with prosthetic feet, we rely on this cantilever. The issue comes that if we haven't been able to build up that deflection enough, we have to have movement at the toe to have enough resistance. So if the patient doesn't have their weight over their toe, they can't necessarily experience that. So when we talk about rollover shape, this rollover shape is very consistent. It's approximately 30% of the leg length of the patient, and it is proportional. So the rollover radii will be exactly proportional to the height of the patient as well, or their lower limb. And this can be really used as a datum for prosthetic foot testing. But those of you that are orthotists are equally excited because this rollover shape should be what we're trying to approximate in orthotic design. Does that make sense? So when we look at the 6 determinants of gait by Vern Inman in 1954, this is how they measured gait. They used to see this lower mirror. They would film the lower mirror and they would actually screw in markers into the iliac crest and sacrum. And this went all the way into the bone. This was a Navy officer who wanted to avoid a math portion of his candidacy to be an officer. So that's just how much people hate math. They would rather have things screwed into their bones and walk on top of a platform with a mirror below them. So anyway, that's how they experienced gait or experimented with gait. So we talk about this minimizing the pelvic motion. So knowing how this moves and how that oscillates is different from patient to patient, but should be within a 4-inch by 4-inch or 100 millimeter by 100 millimeter box. That's actually a cube in terms of translation and oscillation of the pelvis and forward and posterior fore and aft movement. So when we look at these challenges, Childress and Gard looked at this and found that the 6 determinants of gait were a little bit in question because the movement of the pelvis wasn't necessarily in correlation to this minimization of the pelvic oscillation. So they began to think about maybe there are 2 forms of gait. So the 2 forms of gait, we typically think about the inverted we typically think about the 6 determinants of gait, which is to minimize that movement. So the knee flexion at heel strike is what's eliminating this. The inverted pendulum, however, says that oscillation is not only, should it not be minimized, it may be necessary for walking, and says the inverted pendulum, the leg is attached to the floor and arcing. So these things are important to you in orthotic design as well. I think this will work. It shows we can make robots with an inverted pendulum, and you can see these on YouTube. Actually, this was a little robot that was on YouTube. That would show you that it would walk on a treadmill, and it walked for 30 minutes, but it has no motors. So that shows you just how eloquent the gait cycle is with minimizing the amount of energy. There are other robots too that show us this. And the foot design they employ is that rollover shape. So that rollover shape is really important not only for those passive robots, but for Asimo. Now, Asimo uses the 6 determinants of gait, so he keeps his gait very minimized in terms of the hip. So the definition of the rollover shape, as we mentioned before, if we look at the center of pressure with the shin, and we now hold the shin, let's say we attached a GoPro to the shin, then we can see how the rocker shape of the foot arcs. And that describes for us how things move. This has also been mimicked in terms of how if you put a weight on a foot, if you put a dumbbell or a heavy weight, 40 pounds, and then rock over the foot, you can see the same type of rollover shape. This also shows us the effective foot length. Now, your effective foot length is about 83% of your foot. Your toes also contribute quite a bit. That's why patients that are missing their toes, especially their big toe, are compromised because they can't carry their load all the way to the end of the foot, so they minimize the time spent on their foot. And this also has great application in orthotics. So when we look at this, we try to when we use a carbon foot, we're trying to mimic this biomimetic deflection. So we're trying to approximate that for each patient. And some patients like more flexibility and some patients can tolerate less. Even today, one of our patients who hadn't walked before with her transtibial prosthesis, she was missing her arm too, so her balance was compromised. So even though she was young and wanted a very flexible foot, we had to use a foot that was quite a bit stiffer to provide that stability. Now, when we looked at changes to the rollover shape, when the patient walked faster, there really wasn't any change to the rollover shape. There were only 2 forms. When the patient was standing, the foot actually flattens. The rollover shape is almost eliminated, but when you start walking, your physiology actually adapts and begins to allow that rollover shape. One day I was in a store and I was watching someone walking in their sandals, and I noticed how their toes actually abducted, and they were wearing those clear sandals so you could see their toes, and they spread in late stance, and I was able to see the effect that toes really had. Of course, my wife asked me why I was staring at people walking in sandals, and I had to assure her I was looking at the toes, and because she's been quite patient with me in my pursuit of biomechanics, she said, I think that's exactly what you were doing. I do believe you. Yeah. So when we look at this type of thing in rollover shape, heel height actually had no effect either. In fact, all heel height did was limit the amount of the effective foot length. That's why I don't wear high heels, but if I did wear high heels, the rollover shape is the same, but it makes your feet and your calf muscles work harder. In fact, because they're working so hard, that's part of the effect. But we know in terms of trivia, high heels originated in Venice for men, by the way. So that's kind of interesting. So when we look at terms of orthotics, we also look in terms of weight. Now, weight did have an effect in flattening the rollover shape, but the muscles worked harder. So for bigger people like we have in Tennessee, where I'm from, these are about the average size people. The pendulum, the reverse pendulum, the patient was working harder to maintain that rollover shape. The question we answered Tuesday was, does rollover shape change when you're walking up or down a hill? And the answer is it does not. Rollover the shape is the same uphill, but your ankle is working to change that position on the surface level it's working. But going down a hill, it's really kept at neutral, but your knee is working harder, which makes sense because when we dealt with patients who are transfemorals, you could see when they're walking up and down a hill, going up a hill is no problem, but walking down a hill is much more problematic. The effect of standing, as you can see, this is the rollover shape when someone is standing. You see how the foot adjusts and makes it much more flat. Now, this is the typical orthotic rollover shape. There have been some studies that looked at orthotic rollover shape And they find that most of the materials we use, and it's very humbling, have very little or no effect. Even prosthetic feet, they have a number of different types of rollover shapes, but this is what the prosthesis does. The one prosthesis makes all of the rollover shapes that were designed by the engineers into one that looks very similar. In fact, you can make a rollover shape out of a piece of wood. And they actually tried this out of a patient in Northwestern, but because the patient was knowledgeable of what type of foot he was wearing, they made him wear this giant paper skirt to blind him from it. And he still could tell that it was a plank, but he did say it did feel very realistic on normal surfaces, very similar to his flex foot. So when we look at feet, the one issue we have is feet have to fit into a foot shape, because we can't make a wooden foot that looks like this. People would question how good a prosthesis we are if we allowed that. So we have to make it fit into a foot, and that's where the carbon feet come into play. Jacqueline Perry in the 1980s actually studied the rocker shape in wooden clogs and found that patients were very safe in those wooden clogs. And so here's the question about orthotics. How much can we manipulate this? And what we found is that without the use of carbon, with just the use of thermoplastics, we had very little effect. So I think there's a lot of work that can be done for orthotics. And then when we use the rollover shape, if we can find the rollover shape or ask the manufacturer for that, it can tell us how the foot will operate in the end. The other thing is really looking at the effective foot length. Are we as prosthetists aligning so that the patient is over their toes, latent stance? And this is the same thing true for therapists. Are we teaching the patient to take a footstep out in front of them, or are we having their shoulders erect, leaning over the forefoot to build that deflection of the prosthetic foot? And then when we have static alignment, that fore and aft position is very important to tune the foot. Even in modern feet, the problem is the attachment is right underneath of the socket. So sometimes we need to have a slight anterior lean in the transtibial. Yeah, I had much more videos to show you of rollover shape, but I thought it was interesting as a precursor to our next lecture in orthotic design. So we'll just stop this one, thankfully. And then we'll move on to the review of lower limb orthotics. So when we think about rollover shape, when we think about manipulating how the foot works, this has a great effect into what we're trying to achieve with orthotics. Now, orthotics is related to the word orthogonal. And orthotists are related to the word that means one who makes straight. So our job as orthotists is to make things straight again. Good, finally. All right. So an orthosis is technically an external device used to modify a structure of the neuromuscular system. As orthotists, we are one who makes straight, and we are from shoemakers. As prosthetists, we are from the ancient line of armor makers. So you can choose which one you want to be affiliated with. But our main goal is to manipulate this ground reaction force. So what we want is a strong ground reaction force and maintain that stability while the patient walks. So we want to make sure we have good stability in early stance, but then also allow movement latent stance. And this is sometimes the issue for us. We overstabilize things at heel strike, but make it very difficult or impossible to move the leg latent stance. So it's this ground reaction force that we need to be aware of and how we manipulate it. Now, another thing is contracture management. Contracture management is a sub-specialty of orthotics where we're really trying to stretch the patient to allow that mobility. So it's not just about force, it's about positioning. So when we look at intervention options, we can apply a low stretch over time or at night, or we can use casts to help position the child or the adult's foot and ankle and knee in the right position. And this is what we would use for contracture management, something that would dial things into a particular position. And I want you to notice in this picture, what's that? That's the rollover shape again. So when we look at goals of orthotic intervention, number one is to prevent the deformity. So we need to prevent the deformity from occurring or at least slow its pace. Number two is to assist in locomotion. So what we do is we prevent the deformity or correct the deformity. And oftentimes these are opposite things of each other. Correcting a deformity may be eliminating, for instance, knee flexion contracture. But maybe that has become fixed, and now we need to accommodate that knee flexion contracture by dorsiflexing the foot and allowing hip flexion, you see? So there's differences. They're almost exactly the opposite. The third thing is to maintain that correction, once we've achieved it, and then slow its progression as the pathology history continues. Another main principle is something we call the 3-point pressure system, and this can be in the sagittal or coronal plane. So when we look at the 3-point pressure system, we have pressure at the end points and in the middle. Also in the coronal plane, we have medially directed force and then a laterally directed force, and the opposite is true in the lateral positioning. So this 3-point pressure system is not only for the lower limbs, but for the spinal column as well. So our levels of intervention, and I don't mean to bore you with them, but they are very basically foot orthosis, supramoler orthosis, ankle foot orthosis, knee orthosis, knee ankle foot orthosis, hip knee ankle foot orthosis, hip orthosis, and reciprocating gait prosthesis. So the foot orthosis really looks at the 3-arch support, the one in the medial longitudinal arch, the lateral longitudinal arch, and the transverse arch of the just proximal to the metatarsal heads. The other thing is to provide this heel cupping to maintain the neutral position of the calcaneus under the talus. We don't want to have a inverted or everted hind foot that can actually contribute to the opposite of a forefoot. So we maintain this in open or closed chain positioning. Open or closed chain positioning means that the foot is flat on the floor. Open chain means when you lift the foot up. My concern as an engineer, and I do suffer from that affliction, is that I often concentrate on the closed chain because that's when all the bad things happen. An open chain, that's just for how it appears, but the closed chain is when I'm usually looking at an issue. So we think about medial or lateral posting, and sometimes this can be opposite if you're trying to accommodate the hind foot or if you're trying to correct the hind foot. So if typically in a pronator, you have an inverted hind foot in the open chain, you're going to post the lateral side. If, however, it's permanent due to arthritis, you'll post the medial side, and posting means putting a wedge in the hind foot. And then in the forefoot, if you have a pronation, you'll typically wedge the medial side. So you can see why this becomes somewhat complicated. And the foot really forms the foundation to all orthotic design. Most of all, you need to support this arch to maintain the talus, which is a non-vascularized bone that floats in the joint capsule of the ankle. In the old days, they used to call this astrologus. They used to predict the future of this from pig bones. They would say, okay, well, let's roll the dice. That's where dice came from. They were from pig bones. But anyway, I got off topic. But you have to maintain this in the neutral position below the tibia. And we do this by positioning this arch, those 3 arches. Now, moving up the ankle, a supramoler orthosis goes just above the ankle and is usually articulated, but it can be non-articulated. This is a supramoler orthosis here. Normally, what we're trying to do is provide minimal control in the frontal plane, but provide a little bit of stability in the sagittal plane. So it's very short, but we're really trying to contribute to that movement, especially for children with cerebral palsy. So it's free in the sagittal plane, but it's really to correct the position in the frontal plane. An ankle forward orthosis is really for ankle instability or deficiency. And again, the main goal is correction of the deformity, the position of the tibia, and to compensate for weakness. Now, typically we see this with patients with paralytic equinus. I'm not sure how it's said in Spanish, Espanol, but we would say drop foot, right? And drop foot is one of the oldest pathologies described. It's when you bump your peroneal nerve a number of times, and the peroneal nerve, have you ever hit your foot and your fourth and fifth toe begin to feel like they're tingling? And that's your peroneal nerve. And if you hit that enough times, unfortunately, as an older person, when you begin to lose your muscle and some of your viscera that kind of pads that, you begin to lose function of the ability to dorsiflex. And so what happens is, because you can't dorsiflex latent stance, you end up picking your knees up farther. And these are very easily identified socially. So we call this paralytic equinus. It can also be secondary to a cerebrovascular accident. Now we would actually choose to use a KAFO. We use an AFO if Jenny-Reeker-Vadim, in this case, of a post-polio patient is less than 30 degrees. If it's greater than 30 degrees, we really need to think about a KAFO. Now, in this case, 30 degrees is not very much. Would we still use an AFO in this condition? And the answer is most orthotists would say absolutely not. We would go to a KFO. We want to reposition. Now, those of you that deal with post-polio patients, even though their knee may look like this, they'll resist you actually positioning their knee in the correct position because they feel less safe. They feel like you're pushing their knee into a position that's going to cause them to fall. So they'll actually ask you not to do that. They would rather have this where they know their knee is locked because they have proprioception, but they don't have, they have paralysis, but they still know where their knee is placed in space. So the types of AFOs that we can use metal, we can use polymer, or a hybrid. Now, the thing about metal is certainly it does look not very good, and plastic looks a lot better, but metal has certain advantages too. Metal can be reformed. It's not at all hot, and the area that you need to have it, it's very strong, right? So metal has really great advantage. One advantage it does not have is it's not very cosmetic. I think my great-grandmother actually wore a form of AFO like this one because she had I think she had transverse myelitis, but in my great-grandmother in the 1930s, I think they didn't have that diagnosed. So when we use plastic more, plastic has certain disadvantages. One is that it is weaker. Two is it really dampens motion. It doesn't imbue any sort of movement. And so axial resistance is really better with the metal. And you get dampened movement, but you still allow movement. Now, in the modern times, what types of materials do we have that can give you even more response are prepregs. So you can have other materials like enhanced thermoplastics. You can also have prepregs, which give you the advantage of plastic, but also the advantage of metal because they can be rolled into a prepreg round reinforcing member and then inserted with a polymer foot and calf section. This gives you great, in a sense, prosthetic combination because it gives you good coupling of the foot and just below the knee, as well as the strength in the midsection as well. So this hybrid design is really where things are moving toward. So as I mentioned, metal AFO, very uncosmetic. You can still adjust it. It's not very hot at all, actually, but it's just, it can also address localized pressure. And the shoe is usually attached. So the shoe uses this stirrup on the distal section. So knowing how these things are working together, the calf band, the upright, the varus or valgus straps, And this is how the prescription is developed. How we make a metal AFO is usually from a tracing and then a tracing board. So we first find the ankle, we first place the foot in the correct position, and then we make a schema, which is a form or tracing of that device. That schema or tracing helps us establish where that knee should be placed, even without taking any sort of cast. So these foot stirrups can either be solid or they can be calipers. These foot stirrups are inserted into the shoe. So that's the shoe you have to wear when you're using your orthosis, or you can use caliper stirrups that can be pulled apart and put new ones in. The problem with those is that you usually lose some sort of rigidity. The fill-hour stirrups were adjustable somewhat, and you could have different types of tongues. Now, these tongues were interesting because this could influence that rollover shape they were trying to affect with the foot. So a solid stirrup has to be ground into the shoe. There's nothing visible, but then it's very uncosmetic. You can use a caliper stirrup, which is not as strong. You can spread this apart, and over time, it's inserted into the shoe. It's easily twisted, though, if the patient were to fall over. Other metal ankle joints. In the US, typically we use integrated ankle joints where the bar is actually forged with the joint head, so you don't have to attach them. I think in Europe, oftentimes they use a screw-in type joint, but there's a difference between how we attach them. In Germany, for instance, they like to screw them in, and they put the joint, the bar on the inside to make it very smooth in terms of the cosmetic shape. In the US, we put it on the outside because we don't want to hit the ankle joint. Either way, it works about the same. It just depends on how good you are at bending metal. Have any of you bent any metal for the uprights for an orthosis? That's always a good experience when you first try to do this because it is quite a bit of an art. But most of the people that bend the metal, they only do it in about 3 bends, and they know exactly how to do it. But they don't tell you that it took a lot of practice. Yeah. Now, the types of joints we have, there's one that's a free motion joint. So it's really to correct the ankle movement. This is called a double action joint, meaning that it provides resistance or assistance through the use of springs or stops. Stops can be screwed in to limit dorsiflexion or stop plantar flexion. So to stop plantar flexion, you put a solid rod in the front, and then you put a spring in the back to assist with plantar flexion. So normally there's different combinations depending on what the patient would like to do. The issue is, though, most of these are just preventing motion. It's not like using carbon devices that allow actually more energy to place into the system as you move. These dorsi assist. This is providing dorsiflexion assistance where the spring is posterior and lifting the foot up. The thing is, it sounds quite complicated, but for the most part, you're going to use a dorsi stop in the anterior and a posterior spring, most always, because the patient wants to lift up their toe and you want to limit the amount of dorsiflexion movement. Now, why would we want to limit dorsiflexion movement? Well, the answer is that when you limit dorsiflexion movement, you increase the biomechanic tendency toward knee extension. So even if the orthosis doesn't work above the knee, an ankle orthosis can affect how the knee works. So there are smaller versions of these for children. So you can use these stops or springs, but most often it's an anterior stop with a posterior spring. Now, this is what I mean by the dorsiflexion assist orthosis. And this was also known as the Clenzack joint, which is an interesting story. Clenzack was an engineer in Kankakee, Illinois, not far from my home. But he developed this as an easy way to help lift the toe for people with paralytic equinus. And this was one of the more popular devices used, and this was used for drop foot. So really it's to provide a dorsiflexion assist, but not a plantar flexion resist. Now, something that's new, something called a triple action from Becker, or there's another joint from Autobot called the Tango, and these have supercharged springs. So not only do they provide dorsiflexion assist, plantar flexion resist, they actually assist the toe and move in plantar flexion latent stance. And this is really exciting in terms of orthotics because it gives you the chance to provide prosthetic movement for your orthotic wearer. It allows you to actually load the toe and then have that release in late stance. So these are other types of toe pickup or Clenzack joints that you can get that they're very small for children, or you can get them larger for adults. And the main goal is to really affect this change in the control of foot drop. So rather than having the toe pointed downward when they go into heel strike, their toe is kept up in the air during swing phase so they don't trip on their own feet. So this is what I mean about the double action joint. You can put a combination of springs and stops, and you can adjust this to the patient, but it's really about the joint movement that you're trying to control and stop. The other area we have to think about is not just sagittal plane movement, but we also have to think about what we're trying to achieve in terms of coronal or frontal plane movement. So we could use a thing called a T-strap, and a T-strap goes on the lateral side or medial side to evert or invert the foot. And we see this if there's flaccidity in general. So when we fit the conventional AFO, we're really looking to make sure that the proximal trim line is 20 millimeters distal to the fibula. And we like to say it's at least 1 finger width difference. And just because I had to, I measured my finger to calibrate it, and my finger is calibrated to exactly 20 millimeters. So if it's below the neck of the fibula, which is a drop off, we will not pinch onto the perineal nerve. Has anyone ever heard of the world's tallest man from the Guinness Book of Records? His name was Robert Wadlow. He was 8.5 feet tall. And unfortunately, he died prematurely. He was only, I think, 29. And the reason he died is because his orthotist formed his proximal trim line too close to his leg, and he actually got blood poisoning because his braces fit so poorly. And it's a sad story, I think. Yeah, maybe I shouldn't have told it, but that's why it's so important to make sure that your AFOs fit. Yeah. Okay, so then we want to make sure that there's 3 to 6 millimeters clearance between the ankle and the sidebars. And this is something that I made the mistake of when I was a young orthotist. I would try to make the metal fit as tightly as possible near the patient's leg. And the reality is you want to have about a bit of space between the leg, because as they're moving, the leg has a tendency to move back and forth. And I had to learn the hard way that we want to have 6 millimeters of clearance along the medial malleoli and 5 to 6 along the lateral malleoli. Now, polymer AFOs are a bit different because they can be formed directly to the mold, and this makes them very cosmetic and give you much more contact. So plastic is inherently much weaker, right? Metal is stronger, but you can't touch the patient. If you look here, I'm only touching the patient at the foot and at the cuff, really, right? But with plastic, I can get it much closer. So even though it's a much weaker material, because it makes contact along the entire leg, it gives you much better multi-point control of the leg itself. Now, the downside, of course, is that you have a big thing of plastic on your leg, and it can get quite hot in the summertime. I think here it could get quite hot. And so sometimes that can be a real issue for people to wear this high plastic device. The thing that you can do to alleviate that is to use carbon, and carbon could be made in strips along the side of the legs. So you get the strength of metal, but you get the contact of plastic. So you get the best of both worlds. So with the polymer components, you have your calf strap, you have your upper section, and then you can choose any sort of joints you have. These particular joints are known as Tamarack joints or free motion bendable joints, and they're made by Marty Carlson at Gillette. He created these and called them Tamarack joints. We don't have to articulate with the polymer device. We can make a solid ankle. Certainly prosthetic feet don't always have an ankle. In fact, I would say only about 20% of the time would you use any sort of prosthetic ankle. But you would put pads on the malleoli and you would load this, and it would really provide that frontal plane support. It would allow the certain movement to the late stage stance, and then provide that coronal plane correction. Another type is called the posterior leaf spring. Now, this type of orthosis is really used only for sagittal plane control, PLS, posterior leaf spring. So it's really to provide dorsiflexion assistance. So normally you cast the patient in slight dorsiflexion. Why would you do this? Why would you cast them in slight dorsiflexion? Because you really want to allow that certain movement. Now, if you wanted to preload the system, you would cast them in slight plantar flexion. You'll notice how thin this device is, and that's because we're really not correcting the frontal plane. We're really just correcting the sagittal plane. And a posterior leaf orthosis is probably most often used for drop foot. Now, can you think of any carbon composite orthoses that are used in the very same way? Yeah. So there's a number of carbon devices called the Allard brace. We have the walk-on device from Philauer. There's the other types of carbon type devices that you can utilize that control this rate of dorsiflexion, either slowing it in early stance with an anterior panel or allowing that and addressing the late stage stance. So actually the anterior panel addresses late stage stance, and the posterior panel addresses early stance phase or heel strike. So the polymer trim lines are important because you influence how flexible the device is by where you trim it. So if you use this first line would make it very stiff, but if you use this other line, it would actually make it much more flexible. Now, if you needed even more flexibility, you could convert this device into one that uses plastic for the foot and then articulate with the joints. The issue with plastic is, though, there's a lot of torsion in walking, up to 25 degrees, 23, 25 degrees. Plastic really torques quite a bit, and metal acts to control that. Now, when we're really just trying to address, we want to allow free motion in the sagittal plane, but correct the frontal plane, that's when we have these free motion joints. And the free motion joints can be made of a urethane flexible member, or they could be made of a free motion actual metal joint. This particular one is made of a swivel joint that can rotate into position. And the reason this one is so good is because when you think about how your ankle moves, the point of movement is at the distal tip of your ankle. So as you're sitting in your seat, if you can point to the tip of your medial malleoli, that's the point of rotation. Now, if you look at your lateral malleoli, that's actually moving in a cone shape. It's a polycentric joint on the lateral side. So that's what makes it so difficult for orthotists to find the center of rotation on the medial and lateral side. So the next is using the upper AFO portion, and we can influence this, what we call Sablich flanges, developed by John Sablich, probably more famous for ischial containment, but these Sablich flanges really influence the amount of rotation and stiffness the patient has in the upper member. So it's increasing the shear force. It's actually quite an engineering issue or engineering solution. When you increase this resistance to shear by increasing the cross-sectional width, you influence that rigidity of that device. Now, a ground reaction orthosis, sometimes they'll call them graphos, ground reaction ankle foot orthosis. This has an anterior panel, and the anterior panel is meant to push into it and provide extension at the knee. So the orthosis, if we needed more extension at the knee and the knee was in stabilized position, you could use this ground reaction device. It's usually with people with quadriceps 3 to 2 plus. And the reason is if they're weaker, it'll force their knee into recurvatum, into extreme hyperextension. Sometimes though, it's difficult to don because you have to slip your toes through the front part and then put it into position. So you have to work with the patient in terms of how they don that or put on that orthosis. Now, another one is called the crow walker. And it's not named the crow walker because it's black and it looks like a crow's foot. Although many people in the US think this, it's actually called that because it's called the Charcot Restraint Orthotic Walker. And just like these devices can actually be made for people with prosthetic partial feet, we call that a prosthesis because it's a combination orthosis and prosthesis. It allows loading of the toes as you lean into it in late stance. The crow walker with a rocker bottom helps eliminate some of the pressures on the foot, especially during rehabilitation. So this rocker bottom, and we put the foot in there, we don't necessarily need to wear a cast. We can be ambulatory. And due to something we know as Wolff's Law, the more we load bones as they're healing, the stronger and faster that fracture will heal. So if we have someone with a surgery of the midfoot, we put them in a crow walker and they could ambulate. When I was younger, we used to make these custom made, and now you buy these basically off the shelf, but they don't necessarily always fit your shin. So sometimes I worry that they're not maybe the best, but they're what insurance will pay for. Now, another level is called the axial resist orthosis. The axial resist orthosis, I have to say, is not made very often, but it was pretty interesting. It used transtibial socket design to lift the patient up with their tibial medial flare, with the patellar tendon bar and the popliteal loading. And this helped unload the foot itself. Most of the time people will use crow walkers, but this was used with a bivalve where the patient will put their leg through here and this would swing down into position. And they would use it to accommodate heel ulceration. So if they got a surgery or if they're a diabetic and had a heel ulceration or skin breakdown, this would help lift them up. But if you didn't achieve your goal, or if the patient had maybe obesity, you couldn't lift them up enough, this really didn't function. So finally, we've gotten to KAFO design. And the main goals are to control the knee flexion and extension, the ankle dorsi and plantar flexion, and then genu varum or valgum. So the indications usually are any spinal cord injury from L2 to T10. We're looking for the benefits of decreased contractures and upper limb strength. But basically, we're not really allowing knee movement, right? We're locking the knee into position so that it doesn't have that degree of freedom. This is, however, changing with the use of microprocessors with knee design like the C-brace and other types that allow that knee motion. But in the sagittal plane, quadriceps that are less than 3, genu recurvatum more than 30, or we have a presence of a knee flexion contracture, and we have genu varum or valgum in excess of 10 degrees. Then we want to reposition or correct them in the correct position. So the goals of the KFO are to maintain the femur on the tibia, maintain the neutral position of talocrural joint, and then correct the deformity. You've heard this before. Compensate for the weakness and prevent the deformity. So the biomechanic principles are the same with the 3-point pressure systems. We're really trying to control the endpoints and apply pressure through the middle, although we don't typically put pads in the middle. But we can use a metal KFO, which we can contour, and you can see how small that is relative to the patient, although, it's kind of unsightly perhaps, but it's less heat and more localized pressure can be applied. Whereas a polymer KFO looks more cosmetic, this one has anterior position thigh cuffs, and this is to help the knee be kept in extension. And there's increased triplanar control because even if the plastic is weaker, it still allows the patient to, because there's so much points of contact or pressure gradients, it controls their positioning. Now, the nice thing too, though, is to have a combination of plastic and metal to get that good force coupling with the KFO. And sometimes we do apply a varum or valgum pad, an extension to help push the patient, for that middle point of pressure in that 3-point pressure system to get their leg into the correct position for ambulation. Now, the types of knees that we have typically are locks. They could be drop locks or what we call cam locks, step locks. All of these devices really work to lock the knee out in different ways. The main types are drop locks, which are very simple, inexpensive. But then if the patient wants to sit down, they have to lift up these rings that go around the knee joint. These are called French locks if they're, if you can see them outside of the device. They're called Swiss locks if they're covered, because sometimes they cut pants. So here we have the drop locks, which fall into place when the patient stands up. You can actually hear them locking down. Sometimes you can attach a ball retainer to keep it in the up position if they want free motion now and then. A cam lock is where this device, or called a Kelly joint, also moves into the slot. So you can just grab one trigger and help lift it. And then another type is just a pin type lock. But there's actually quite a bit of localized force. In terms of engineering, this is a very difficult engineering issue because the tolerancing of the knee on both sides of your clevis, as well as the locking pin, all have to work together to allow it to lock. And over time, things begin to wear. So sometimes the patient's locks begin to break down. So the problem is there's only one point of locking. So how do we overcome this? And we overcome this with a thing called a step lock. A step lock is something that allows you multiple locking positions. And this is especially good for children if you don't get to full knee extension. If you can only get to within 30 degrees, this will still keep you safe and prevent you from falling. The downside, of course, is these little steps can wear out over time. So with pediatric patients, maybe they have cerebral palsy, you can use a step lock, but you can also use it to progressively stretch out any sort of knee extension contracture. And that's what this dial lock is meant to do. Over time, you'll begin to dial out their knee extension or flexion contracture, and then they'll be able to get to an extended knee over time. Now you can get a thing called a posterior offset joint, and this is a more bulky device, but this is one principle that orthotists can enjoy from prosthetics. Prosthetists are able to position the knee joint posteriorly, and that increases the tendency for knee extension moment. And orthotists can use these offset joints to actually increase the knee extension moment as well if the patient doesn't need to lock the system out. Now, the new thing is these, let's see if this will play. No, are these stance control devices that lock and unlock. I think it was around the 2000s. I had a therapist ask me, could we just lock the knee during stance and unlock during swing? And at the time, we didn't really have that. But by 2005, there were actually 4 different designs that used mechanical systems. The downside is those things worked really well for surface terrain, but then when you walked up slopes or went down slopes, they didn't work as well. So now in modern times, we have this thing called the C-brace that can actually detect the position of the knee and borrow from the C-leg and allow the patient to walk or up or down slopes or downstairs. Now, in terms of axial resistance, we also have a thing called an axial resist KFO, which loads the ischium the same as a transfemoral user. And this is for malunions of fractures when you want to unweight the limb, And you have to use a locked knee joint for this or arthritic conditions. So the fitting criteria for KFO, you want to be within 35 millimeters of the perineum, or in this case, 2 fingers. If I measure my fingers, that's at least 35 millimeters, but you do want to have it as high as possible. I have noticed a number of orthotists fitting quite a bit lower because they're afraid to go very high, but you have to make an arrangement with the patient because in terms of engineering and physics, we want to have the endpoint as high as we can, and then the lateral side at or around the trochanter within 10 millimeters. And the knee joint should be 6 millimeters clearance medially and 3 laterally. So what we want to see is the patient be able to sit down and have the knee joints aligned. Remember that the knee joint is polycentric, so it's often difficult to achieve that. Most of the time, it's located about 40% posterior from the anterior, 60% from the anterior of the knee. And so that's where we place it near the medial condyle. Does anyone notice how the orthotist cheated here to make sure that the knee centers in the right spot? They used an offset knee joint. That offset knee joint appears to move posterior. And what really the main benefit of that is they wouldn't show if you were wearing pants. So the fitting criteria of the KFO is the same for the ankle as it was for the AFO. So we'll jump over that. And now we come to knee orthoses. How many of you worn a knee orthosis for sports, right? So knee orthoses are becoming much more common now. If you can get a custom one, you get much more protection of your limb, and they're made with carbon and metal for that conformability, but also strength. So usually it's for arthritic conditions, but often due to sports injuries of your ligaments. You'll notice a lot of American football players use them prophylactically to prevent injury, although sometimes they're concerned that they actually cause them. You can buy custom joints if you want to make your own custom knee orthoses, but most of the time, most knee orthoses are purchased off the shelf. And finally, we're coming to hip orthoses, and these are used for leg calf perthes or Scottish or other types of injuries of the bone or deficiency of the bone to actually keep the leg into abduction. The acetabulum can be used like a jello mold if the head of your femur is injured in some way or has a flat spot. So even if this necrophies or due to a fracture, like Bo Jackson, you can actually have if you keep the leg abducted, you can position the head of the femur so this will grow back into position the way it should and avoid any sort of permanent deformity. So the Pavlik harness works in many of the same ways. This is an orthosis that keeps the leg into abduction, and the Scottish Rite does this for older children. And then finally, hip abduction orthoses for post-surgery when you have hip replacement. Then finally, we come to HKFOs, and sometimes these are a little bit controversial because do they really necessarily work? We're looking at correcting the deformity and competency for weakness, but also allowing for biomechanic mobility. This is a small child with spina bifida that's wearing an RGO or reciprocating gait orthosis, and that is attached to the HKFO to allow mobility and standing. Many times these are only used for children, although adults can also use them as well. So we've covered quite a bit in terms of this overview of orthotics. And if you're a little confused, that's okay, because there's so many things to know. And as an engineer, I have to say orthotics can be very frustrating because as a prosthetist, it's very easy for me, an engineer, to replace things, realign things, and away we go. But as an orthosis, with an orthosis, I have the leg to deal with. And in many times that mechanical system is imperfect and getting worse over time. And my goal is to stop this bridge from falling into the water. So, orthotics, we really have to look at the kinetic chain and what types of things are we trying to achieve? Yeah. And so are we really looking at the deformity, correcting the deformity, accommodating it, and then allowing mobility? And with children, this becomes even more problematic because we have to look at where we want them to be in terms of ambulation 10 years down the line. So that's the overview of orthotics. Are there any questions? Let's take a little question break.
Just raise your hands if you have questions. Through the internet, we have some people thanking you for this conference. We know that this world of orthosis is very complex, and one of the questions was, I think that you have answered, what is easier to do, a prosthetic device or an orthotic device?
As an engineer, I would say the easier thing is a prosthetic device, because prosthetics, it's one pathology, amputation, but many different components and some equally valuable. With orthotics, we can have hundreds of pathologies, but only maybe 3 choices in terms of componentry. So that's what makes it a little bit more challenging.
Another question is, they say that it seems by the image that the kingpin is a polycentric joint. Is that true, or all the joints, the orthotic joints, are monocentric?
No, there can be polycentric joints. They're not as often used for, I wonder if this is an engineer asking the question, because I thought that when I was a young engineer too, that why not use polycentric joints, because they have variable stability. The problem is, as with many things in prosthetics, orthotics, the patient has to wear it. It can't just be a science fair project. And when they wear polycentric joints, which have been developed, they tend to pinch the clothes and cause holes in the pants. So if you don't want to buy pants for your patient all the time, they're not advisable. Yeah. Okay. There's not many polycentric.
Question here. This world of orthotics is so big that they have to take 2 courses on orthotics for the lower limb. So
yeah, that's
just
why,
coursing.
Yeah.
The most advanced students are just coursing the first one. So I think that this is a very nice summary of what they will learn.
The first semester is probably just spent understanding pathomechanics. And then the second semester, how do you answer them? Because there's so many types.
Any question? Okay. So
hi.
Hello. Hola.
Have you ever made an reciprocating gait orthosis, and how was your experience?
I'm sorry.
Have you ever made RGO orthosis?
Oh, yes.
How was your experience?
So I now work for Autobach, but I used to work for Philauer for many years. And we used RGOs for children and for adults. And my experience has been that for the most part, they work very well for children to have them upright. It helped them in terms of freeing their arms for mobility and also learning, right? And so with children, they worked very well, but they had to be fitted properly. If they weren't fitted properly, they should be with a slight anterior lean on the ligaments of Bigelow, so upright. Unfortunately, sometimes they were fitted poorly. The one thing in terms of studies, I think there was one by Jim Campbell, he saw that there was a great energy cost, maybe 4 to 6 times the energy cost of using a wheelchair. The question is, no one asked the patients what they thought. The patients wanted to be upright, and the patients, even if they could only walk within a 15-meter area, one of the adult patients we had, he was a lawyer, he was about 6'4". He liked standing and addressing the jury. And so he was able to do that with the RGO. But there is a certain walk that you have to use. The RGOs harnessed hip flexion, which often remained, because if you look at the neurosegmental orientation of the body, your hip extensors are the first to lose in terms of level of involvement. So if they could harness hip flexion, you could drive the leg and back of them. And so it worked fairly well, but when a patient got very heavy, it became a little more difficult. Yeah. But it's an exciting area. But honestly, I think it's been replaced by exoskeletons. I think in the future, it's just going to be replaced. But RGOs were probably 20% the cost of exoskeletons, I think.
Yes. Oh, thank you very much. Let's proceed with the
Okay,
follow-up.
yes.
Thank you very much.
We have 30 minutes. I apologize for my late start, but we'll continue. So let's put our prosthetic hats back on. So no longer are we worried about bracing. We're going to think about transtibial, and we're going to think about transtibial socket designs. So let's think about this. And they differ from the transfemoral designs that we talked about yesterday. In many ways, people think that transtibial is easier than transfemoral. And maybe that's because transtibial socket designs are more apparent. The skeletal structures are more available than transfemoral, where it's more soft tissue and muscularity. But there's always equal opportunity to make things bad. But let's talk about transtibial methods through the history, and we'll look at just different drivers of change, but also consistent issues that we've seen with transtibial methods. Now, we're going to also talk about the anatomy and some of the changes in materials, as well as scanning and fluid dynamics. So when we talk about transtibial fitting, this is from a Dutch engraving from 1640 with joint and corset, a leather outer, and a wooden foot. And you might say to yourself, that's very ancient, but you could say, well, if we use BOA system here, if we use carbon uprights, and then we use Kevlar reinforced plastic, we would make it the same way in the year 2021. And they had certain advantages with volumetric change. But the other thing too is this is showing you what a wooden socket felt like. And the wooden socket, some people were very good at crafting these. Older prosthetists will often talk about making a wooden socket. And they'll say they were much better, but they really were not. Does anyone want to guess how many ply fit? So a ply fit is thickness, right? So one ply would be the thinnest sock you have. Maybe 2 nylons would be 1 ply. How many ply fit did they have to fit? Usually they would their goal was to fit what? Can you guess how thick? It was about 10 ply of fit. So it would be like if you wore 3 socks on your shoes and said, that's good. That's a good idea. So that's what they typically saw. So with wooden legs, yeah, they took a lot of handcraft, but they weren't necessarily better. And then what they would do is actually mold in the anterior and then squeeze the leg on the center part. But this is the main issue with transtibial methods. You have the skeletal system anterior, and you have the volume you need to control posteriorly. So the transtibial goals, one is they should be comfortable and axial support, meaning standing. And you should be able to index where your anterior distal tibia is. And then look at minimizing that surface effect of shear. And shear can be very detrimental to skin. Shear actually acts to tear the skin. And when you look at the cosmetic gait and appearance, this is also important. As we mentioned, alignment is also important as well for the transtibial. And I think in many cases, we don't try to narrow or make the gait more cosmetic. And then finally, how do we achieve these in terms of our casting techniques? These are locked prostheses from the 1600s. You can see this is one where they had a cushion and they just walk with a bent knee. And they had, what's that? The rocker shape. What? You see the rollover shape in 1640? This was called the Beaufort leg. And I actually was noticing one of our colleagues, Mo Kenny, who's with us this week. He's using a orthosis, the prosthesis that looks very much the same way. But this gave you great stability, barely covered the leg. And so you didn't need to worry about any sort of impingement. This leg's from 1696. You can see you have adjustable distal end. You have a corset. So very lightweight system, very adjustable. And then you have this very fetching high-heeled shoe for a man right here. Mm-hmm. And then in the 1700s to 1950, things had really not changed A prosthetist might actually use a chisel and hammer similar to making wooden clogs. And that's how they would make the socket. And the way they made them was to trace how the patient's limb looked, and then they would put lipstick on the end of their limb, and then they would insert it, and wherever the lipstick hit, that's where they would scrape away that material. It's much the same way the Aztecs made things, right? They would place the stone where the stone hit, then they would scrape it away a little bit more, and that's how they could get such a tight fit. Then they would cut the wooden socket and compress it. So this is actually where the two-stage casting technique came from, but most of the time they were fit with 10 to 14 plies. So 3 to 4 pairs of socks on your shoes, on your feet. That's pretty much the way it was feeling. And then we typically use joint and corset from the 1700s to the 1950s. In World War II, they typically amputated right at the tibial tubercle. Can you find the tibial tubercle? It's really just about maybe 50 millimeters distal from your knee joint. So they really weren't using the knee itself, the leg of the patient, to actually bear weight. They felt that that weight should be supported with the thigh. And the main issue is that the thigh was variable, and the thigh was also not perfect in terms of indexing. However, we might still use the thigh if the patient limb was very not load tolerant. We might still use the thigh with a BOA system and not necessarily leather. The nice thing too, though, about the joint and corset is it had a hyperextension stop, meaning in late stage walking, the knee wouldn't hyperextend. And this is really important for very short limb lengths. Now in 1945, this is a very interesting design. This is called the Latency Method. And what they used was glass beads that were packed into a rubber bladder. And they would insert the patient's limb in here, and then they would apply a vacuum to the glass beads, and it would take on the shape of the limb, and they would pour that with plaster. Isn't that interesting? There was a similar delatency program where they used glass or metal ball bearings, and they applied a magnetic force to it. And when they put their leg in there, they applied the magnetic force, sort of a rheonetic fluid, and they would remove the limb, and there would be your shape of your limb. And then they would fill that with plaster. And Dr. Wu, one of my mentors at Chicago, has talked about the sand casting technique, where you use sand to find the position. This is a great way to capture the limb fast, but what would be the downside? The downside is you're really not compressing the tissue at all. In fact, you're really just compressing the space outside of the limb. This was another type of method. It's called the slip socket. The slip socket allowed movement within the shin, but you can see this was made of metal. And this was very popular in Britain and India because they had metal workers that were exceedingly good at working this metal. The interesting thing about this one is they usually put a rubber ball at the end of the leather socket that was allowed to move up and down, right? And this eliminated any sort of shear stress. Now you could think, well, this is 2021, and by the way, your lecture is very boring. But the thing is that slip socket, that elimination of shear, is present in the same sort of theories with vacuum systems, which we'll cover later. So all of these things are in different forms in history. Now, this is a gentleman by the name of Chuck Radcliffe, who I knew when I worked at California when I was a younger man. So that's a little bit time ago, maybe 25 years ago. And he talked about the two-stage casting technique and the patellar tendon bearing system. So you would actually load the patellar tendon because it's very insensate. You'd load the popliteal area and then custom form the distal end. And that was using the two-stage casting techniques. Now, some engineers, some prosthetists got a little too crazy and overemphasized some of those prominences. So the socket looked somewhat like an Easter Island head, we used to say, when they over-modified. That was not the intention. It was just supposed to load certain areas like the interosseous area, the medial flare. And I have to be honest, when I fit a patient here, I employed those same techniques 2 days ago, and I think I got a much better presentation. We'll talk more about this, but the reason this isn't as popular is because the more you press on the limb, the more you might have liner breakdown. So the question is, are we fitting a liner or are we fitting the patient? One of the first soft materials used for sockets was in 1959, and it used foam rubber. It was really difficult to use because it was a thermoset, not a thermoplastic. A thermoset does not take on the shape of the patient's limb. In fact, it resists taking on any shape. A thermoset actually burns before it takes on any shape, where a thermoplastic will actually adapt to that and conform to that shape. But we used to use this foam rubber in combination with leather to make a very conformable system, but you had to skive panels all the way around the limb. Now, 1963 is when we first start thinking about using the distal limb as your load source. And Guy Bahal in 1963 from France used this, but you see how high those trim lines are? He actually provided suspension over the medial condyle. Do you see this? And I don't know if you can find your medial condyle, but your medial condyle cups inward. Your lateral condyle is fairly straight, and this can actually help with suspension. Even now in 2021, you can still use this when you cast by creating a condylar bed. It actually helps provide greater endpoint control, same as the orthotist. It also provides great suspension. My mentor in Chattanooga, Carlton Philauer, he used a thing called a medial brim, and a medial brim can still be used if a patient has a prominent medial condyle and it's difficult for them to use a liner. You can use this medial brim, which looks like a half moon cookie that you put in the top, and you actually bind this in. Dr. Gerd Kuhn actually used this as well. And this is when you want to make a socket that doesn't have a liner. Now you may think, well, when would you never have a liner? Well, it might be someone who's a mechanic or a farmer that doesn't want a liner to get dirty. We finally start seeing thermoplastics being used in 1969. This was made of a PVC gel that actually cooked on a cookie pan, and then you would layer into a leather liner. And the patients loved these so much, but they were so hard to even recreate. And then 1971, that's when you see the use of the two-stage casting technique. And that was actually derived from the use of wooden sockets, where you would cut the two panels in half and then squeeze the limb together. They did this the same way with the two-stage, where you make a splint, you mold this just like you would an arch support, and then you wrap tightly around the limb. This gives you a very characteristic and a customized shape, but the downside is it involves a certain level of craft, and it involves a certain level of feel for how much tissue should be compressed. And you can see why engineers have always thought to themselves, why do we have this level of craft? Let's find a formula that can have this work better in terms of pressurization, in terms of air or hydraulics. So Zettel and Traub in 1971, they thought, well, what if we put, instead of making reliefs by pushing on the skin, what if we put little pads on top of the prominences like the fibular head or the anterior distal tibia, and then we'll just cast over top of it and we'll put these specialized brims at the top. You can see this W shape that would unload the hamstring muscles in their insertions. Well, those work fairly well, but sometimes you didn't position those pads properly, or the patient needed additional relief. Then in 1974, we started thinking about using foams, and the foams was a closed cell, so it was non-porous. This is where P-Lite was introduced, polyethylene foam or Bach-Lite. And we use this to apply pressure, but also increase the cushioning within the system. And when we think about this, this is something that Carl Kaspers talked about with vacuum. Skin tolerance is really interesting. It can tolerate quite a bit of pressure, almost 100 millimeters of pressure, if it's less than an hour. So if you're pumping your limb, you can tolerate periodic levels, but if you're loading your limb or any sort of skin at a much lower 50 millimeters of pressure for 10 hours, you're going to see skin breakdown, you see. Now he did something, he checked how well people were, how happy they were. And I think it was around 1998, he found that 68% of all patients, 63% are still unhappy with their prosthesis at that time, even with better materials. The thing is that the limb can be loaded. It can be loaded with a greater amount of load, but over a shorter amount of time. Robin Redhead in 1979 talked about this for transfemoral, the need for total surface bearing and hydrostatic. But those two terms have actually flip-flopped in meaning. Total surface bearing actually meant distracting the limb and making it more narrow for transfemoral and transtibial. And hydrostatic meant really just loading it universally. Now, total surface bearing, a TSB, because of incorrect use of the terminology, has come to mean just loading universally, but they forgot about the elongation part. Now, elongation is really important not only for transfemoral, when you draw the tissue away from the proximal brim and elongate the limb, you also do that for transtibial as well. And this creates a loading transversely. The limb is much like a hydraulic bag of fluid. If you can load it equally, and this is the key, if you can load it equally all the way around it, you can create a semi-solid that can support weight. And that's where subischial limb fitting comes from. So hydrostatic requirements are that you must have a static volume, you must load it between 15 to 26 millimeters of mercury, and you must load it between 0.3 or 0.5 PSI, and you must have a frictionless boundary layer. And so you see why modern liners have that frictionless boundary layer, they have that fabric. And that's actually what gets the patent. It's not the plastic itself. The plastic itself is from keratin, from shell oil. You could buy some if you wanted to. But the patent is the application of that fabric to eliminate this friction. If there's any sort of friction, you get shear. And shear is what causes the problem for skin and skin breakdown, because it's a tearing of the skin. Now, Marty Carlson did mention this. Marty Carlson did mention this in, I think, 1998, that if there was a way to glue a limb to a transtibial socket, but then release it, that's what we needed to achieve. And what he was doing was predicting the use of vacuum. And that's exactly what vacuum did, is minimize the perpendicular forces of shear and make sure that they could be actually directed in parallel. The hydrostatic challenges, though, are very simple. Because we're dealing with diabetic patients, are they prone to volume change? They're prone to a lot of volume change. And so the other part is their skin is not necessarily frictionless. Actually, there's some other studies that show the main shock absorber in any prosthesis is actually the skin. It's in series, right? From the foot to the shock absorber, to the sock, to the liner, to the skin. And the weakest point in that positioning is the skin, if it's all in, not in parallel, but in series. So the skin is the biggest shock absorber. So when we talk about the hydrostatic changes, the limb itself isn't hydrostatic. So this is what's kind of the issue. So Åsa Christensen from Iceland in 1986 first talked about this need for elongation, but he used a very weak urethane at that time. He didn't use silicon, he used urethane. And that urethane, he promoted this elongation. And eventually, what he felt using the elongation, he used the thing that called an ice cast. Now, this was a pressurization chamber. First, they used one that was a plastic pressurization chamber, but it was hard because it's so large. And then this rubber bladder he would put over the patient and pump up to a certain level of pressure to try to achieve this perfect fitting. Philauer in 1987, Åsa Christensen visited, and Carlton Philauer created a silicon, the first silicon sleeve, and that was reinforced with fabric. Then later, Åsa created one that was more off the shelf and more elastic. But the two-stage casting technique or custom forming is matching the surface. Have you ever stood on a Alps liner or Alpha liner and thought, I thought this would feel much more comfortable? And the reason is when you stand on a liner material, it doesn't flow around your metatarsal heads. In fact, it loads them even more. So if you think of this as the fibular head, if you were to apply even tension all the way around the tibia, and this is a transverse view of the mid shaft of the tibia, you actually load with the hoop stresses 5 times more on the pressure prominences. So that's why someone that they totally use hydrostatic methods, why their fibular head actually hurts quite a bit, as well as the anterior distal tibia, and they'll ask for some relief. So the thing is, you really need to match this surface. In the 1970s, Ottobock had this thing where they had this gimbal that would load the proximal area. And here's the key for transtibial fitting. If you can have musculoskeletal contouring of the proximal brim, just like transfemoral, and hydrostatic loading of the distal end, that's your winning combination. It's not one or the other. It's always been both of those together. And that's something Carl Kaspers alluded to in 1992. He used total surface bearing, but he applied a vacuum to a plastic bladder. The one issue, though, in terms of engineering, is it really didn't load the hydraulic limb, but really just compressed the pressurization of the skin and just held the plaster very tightly. But it didn't really pressurize the limb itself. And that's what's confusing as an engineer. You actually have to compress human tissue. Human tissue is more like a sponge that you can compress it, right? Because there's micropores inside of the tissue, and the more you load it, the increase the pressurization. Sometimes you'll encounter patients that have lost quite a bit of weight, and their tissue really compresses quite a bit. So that's the craft of it that still might be part of prosthetics and orthotics. Now, in 1994, a fisherman by the name of Bruce Kanya was very frustrated because he was fishing in Montana. So he took a number of his plastic worms. Have you ever been fishing with your father? And he used some of these lures of those really soft, almost chewing gum-like worms, right? And you as a kid, you wanted to maybe eat one of those, but you didn't because you couldn't. Plus they had hooks in them. But what he did is he took his sock and actually melted in his skillet these worms and stuck his sock in there. And that was the first alpha liner. And Bruce Kanya, who owns the patent for the alpha liner and all TPE liners. So that was his innovation. But the TPE, which is thermoplastic elastomer, is a nanostructure of butadiene, styrene, and butadiene. Butadiene being rubber, styrene being, which is a thermoset, styrene is a thermoplastic. And this was how they were arranged. So the butadiene is like coils of springs, and the plastic is like little blobs that would adhere. So we created a hybrid material that was both a thermoplastic and a thermoset. And that's when you see the effect of liners. But just like everything in engineering, there's always an advantage and there's always a disadvantage. And the disadvantage to this device is that once you loaded it or compressed it over time, it would thin out and it would also begin to tear. So what you had to do was apply a fabric outer. Now the fabric outer covering made the shape more round. But do you remember before we talked about if you make the round shape of the tibial socket instead of triangular, you increase the pressure on the tibial crest 5 times. What do? So you have to use both. You have to create relief over the tibia and you have to load hydrostatically. Now in 1999, Aaron Buis from the Netherlands tried to show how socket designs that were using the 2-stage casting technique were worse. So he used the PTB method and he showed there were increases in loading at the medial flare. And this actually, he measured between the liner and the socket and then how other designs actually spread this out. But the thing was that was intentional. The PTB socket design was intended to load the medial flare more, as well as the medial condyle and the distal lateral fibula. The issue is that TSB, or total surface bearing, has been used almost exclusively for all socket designs. And one of the things I just want students to know both today and the present, you do have options in terms of how you fit, and you do have options in how you fit the patient, not necessarily the liner. Another issue with these is elongation. When you look at the distal attachment, that's urethane. That's not That's not the TPE. That urethane has to be used for strength. And what happens is it begins to milk the end of the limb. And over time, you actually see reddening and edema sometimes of the distal end because it's really not fitting the patient in a custom way. So custom limb forming is really important because if you don't, you get back to the plug fit, which is like this. This is the round shape of the original exoskeletal system. Here you can see where the patient was wearing a liner. They have anterior distal pressure, they have fibular head issues, and they have medial condyle issues. And so I had to take this patient and make a much more customized shape, and all those things disappeared. So, and that's not because I'm so great. It's just I recognize the importance of custom limb shape and the effects of hoop stress on round shapes. And so we have other options, multi-durometer custom silicons, but there's always a downside there too. You see, we're surrounded by challenges. These are about 5 times more expensive, and it depends on prosthetists' own creativity to make them better. And sometimes some prosthetists are more creative than others in terms of addressing loading, but they have to do 2 things: provide comfort for the fibular head, see this, and rigidity in the distal area. So we have so many of these incongruent values, right? But even between transtibial musculoskeletal contouring, that's old. Hydrostatic total surface break, that's new. But if we just go above the knee, musculoskeletal contouring, ischial containment, that's new, right? Hydrostatic methods, that's old. You see what I'm saying? It's actually both. We actually use both. And so when we look in the literature, this is a somewhat older study from 2000, but it looked at 255 amputees, and with total surface bearing techniques, 74% reported pain with their prosthesis, and 60% said it was temporarily bothersome, so they had to remove their limb.